Good evening, everybody. Good morning, according to the time of the day. Wishing you a nice day and a nice stay in our department. I am Mohamed Hamdy, Professor of Neurology in Alexandria University. Today, I'll give a talk about seizures and epilepsy. Before starting, let me show you a video and give me your impression about this movement. What type of involuntary movement do you watch? Please respond to the MCQ and continue with me. Regarding seizures, seizures are clinical manifestations of hyperexcitable, hypersynchronized, abnormally discharging neurons. These neurons give abnormally excessive discharge that can be manifested by transient loss of consciousness or transient motor manifestation or sensory manifestation, autonomic manifestation, or psychobehavioral manifestation, or combination of any of the above. So the seizure is a clinical event that has sudden onset, sudden offset, short duration, and tendency to recurrence in a stereotype manner. So seizure is an electroclinical event in which there is abnormal excessive discharge that can be detected by ictal EEG recording. What's meant by ictal EEG recording? Ictal EEG recording, this means that we record the electroencephalogram during the seizure itself. So at that time, we can catch up this type of abnormal excessive neuronal discharge that can be manifested clinically either by one of the above motor, sensory, autonomic, psychobehavior, or even loss of consciousness. It can be manifested by combination of two or three of them. Okay? But this is a seizure. And the seizure is a clinical event. It's a symptom rather than a disorder. What about epilepsy? Epilepsy is the disease itself in which the patient has susceptibility to have repeated seizures. So epilepsy is recurrent unprovoked seizure. Recurrent means more than one. And unprovoked, this means that no provoking factor is present just before or during the seizure itself. For example, if we have a patient with febrile convulsion, fever itself is a provoking factor. So each seizure, when it occurs, we have fever at the same time. We call this provoking factor. So recurrent unprovoked seizure is epilepsy, but recurrent provoked seizures are provoked seizures. Single unprovoked seizure is called single unprovoked seizure and is not considered epilepsy. So, when I face a patient with epilepsy in my clinic, certain questions come to my mind. I need to answer the questions before starting the management plan. The first question is the event the patient or his relative is describing a seizure, a true seizure, or not? The second question, if it is a seizure, what type of seizure? The third question, if it is a seizure and it is focal or generalized, I determine the type of seizure or the cause. So why this seizure occurred to this patient in particular? If I have the ability to answer the three questions, then I start a good plan for treatment. And at that time, I'll be able to help the patient the maximum. Starting with the first question, let us discuss what is the mimics of seizures. They have similar conditions that can mimic seizures, simulate seizures. The first of them we call psychogenic pseudoseizure, in which the unconscious mind of the patient produces the symptom of involuntary movement very similar to a seizure, that the doctor may mistaken it as a true seizure and start anti-epileptic drug without true indication for this because the patient has only psychogenic seizure. He's not faking, he's not doing it on purpose. The unconscious mind of the patient has produced this symptom to escape from severe conflict, severe emotional trauma he had. So to escape from this, he produces symptom on unconscious level. And this symptom may give him the opportunity to escape and get some sympathy. At the same time, you should diagnose it as psychogenic pseudoseizure and start psychotherapy for this patient instead of starting anti-epileptic drugs. So it's very important to differentiate. How to differentiate? The patient with psychogenic pseudoseizure is usually having emotional trauma or severe conflict related to the onset of the event, severe drama. In contrast to this, the patient with true seizure can experience the true seizure even if he is alone, even if he is asleep, even without witnessing. So he's not gaining any certain emotional benefit of the event itself. So the patient that experience true seizure during sleep is usually a true seizure, not psychogenic. Psychogenic pseudo seizure will never occur during deep sleep or during sleep. Then most of the patients simulate what we call tonic clonic seizure. In tonic means we have sustained contraction of all the muscles of the body, including the respiratory muscles, the diaphragm, the chest muscles, the laryngeal muscles, so the patient will experience cyanosis if it's a true seizure. If it is not, the patient will never experience cyanosis. After the end of the tonic phase, usually the patient experience what we call clonic phase, in which there is repeated contraction and relaxation of all the muscles of the body. And this repeated contraction and relaxation may give out tongue biting with blood tinged frothing, may give severe head injury with shoulder dislocation or self-injury. Repeated contraction and relaxation of the abdominal muscles may give self-weighting and self-soiling. So any patient with self-weighting, self-soiling, self-injury, tongue biting, shoulder dislocation, this is usually true seizure, not psychogenic pseudo-seizure. At the end of the seizure, the psychogenic pseudo-seizure usually terminate by emotional coloring behavior, like shouting, crying, kicking, uh, doing something exceptional that attracts attention. But the true seizure usually is so exhausted with he have the tendency to sleep, he has some confusion and headache. So these stages giving different differentiating points to differentiate between psychogenic pseudo-seizure and true seizure. This is very important. Can we have a look about this patient and tell me what's your opinion? Is it true seizure or psychogenic pseudo-seizure? Please give me your feedback on the answer. As we have seen in the last patient, there is no cyanosis, there is no tongue biting, there is no self-wetting, though we cannot determine it because the patient was covered. So mostly it will be psychogenic pseudo-seizure, but actually we have to ask about the onset of the seizure. If the onset of the seizure is during sleep, usually it's true seizure. The end of the seizure is also important if the patient has post-ictal crying or it's more towards psychogenic seizure. If she had sleep and confusion, it's more towards true seizure. So we have to complete the history in addition to the video to collect all the data to formulate a whole picture about the diagnosis. Okay, the second most common disorder or symptom that can be mistaken as true seizure is syncope. So what's syncope? Syncope is a transient loss of consciousness due to transient global cerebral hypoperfusion. If we have transient global hypoperfusion to the brain will be deprived from the two essential materials for its metabolism, oxygen and glucose. So the reticular activating system, which is very sensitive to hypoxia, will have dysfunction and the patient will lose consciousness at that time. So the patient will experience syncope. Usually, the area of the head and neck is hypoperfused at that time. So, what's the most sensitive area in the head and neck to the hypoperfusion? It is the retina. So, the patient with syncope usually experiences just before the loss of consciousness blurring of vision. The second most sensitive area to the hypoxia is the vestibular system, including the vestibular nerve and the vestibular nuclei. So the patient will have giddiness after the blurring of vision, and then he will lose consciousness at the third most sensitive area to the hypoxia is the reticular activating system. On losing the consciousness, the patient will fall to the ground. At that time, the effect of gravity will correct some of the hypoperfusion effect, and the reperfusion will get the patient wake up and complete what he was doing before the event. So there is no post-ictal state for this. It's very transient and very short-lived. So these are the differences between the syncope and the true seizure. Usually, the patient with syncope is standing, and if he's sitting, usually the cause is transient arrhythmias or something like that. But the true seizure may occur with while even the patient is lying down in bed. Muscle tone is usually flaccid during the syncope, but in the true seizure, the patient has tonic, clonic, or clonic. The duration of the syncope usually 10 seconds at maximum, but the true seizure lasts for 2 minutes or more. Syncope doesn't occur during sleep, but true seizure can. In contrast, tongue biting, self-wetting, self-soil, all of these occur during true seizures and very rarely to occur during syncope. If you have EEG recording during the attack, the patient will get epileptiform abnormalities. We call it ictal epileptiform abnormalities if he has true seizure. But if you are recording with a channel for ECG during the attack, the patient may have arrhythmia in case of syncope. So it's very important to differentiate between syncope and seizure. This patient may have colic or pain inducing vasovagal spasm. She fell to the ground. She swayed just before the attack, and at first she experiences some dizziness, the blurring of vision, dizziness, followed by falling to the ground and loss of consciousness. Immediately she got up and completed what she was doing. This is the usual classical history of syncope. It's very important to differentiate. I have seen many cases with recurrent syncope on anti-epileptic drug due to false diagnosis. Please make sure that the patient is not a syncope patient before starting anti-epileptic drugs. So the first question is already resolved. We come to the second question: what the type of epilepsy, what's the type of seizure itself? We have two main types of seizure. We call focal seizure and generalized seizure. The unclassified seizure is usually a seizure that cannot be classified due to poor history, insufficient data, something like that. But focal seizure usually starts from a localized area of the brain, localized group of neurons. We call them population of neurons, very near together. They discharge simultaneously. We call this synchronous discharge. This hyperexcitable discharge gives the clinical manifestation of focal seizure according to its location. If it is in the occipital cortex near the visual cortex, it will give focal visual seizure. If it is near to the sensory area, it will give focal sensory seizure. If it is near to the motor area, it will give focal motor seizure whatsoever. But in generalized seizure, we have complete loss of consciousness as the discharge originate bilateral and symmetrically from all the areas of the cortex simultaneously. So in generalized seizure, the discharge is simultaneous, bilateral, and from all the areas of the cortex at the same time, and is usually associated with full loss of consciousness. Starting with the focal, we classify focal into focal aware and focal with impaired awareness. Focal aware can be motor, sensory, autonomic, whatsoever. We call them motor and non-motor. And focal unaware or with impaired awareness also can be classified into motor and non-motor. The difference between focal aware and with impaired awareness is the patient during the attack itself is still fully responsive and the response is adequate to the environment in focal aware. But if the patient has focal with impaired awareness, he's responsive, but the response is inappropriate to the environment. And even after the event, he cannot remember anything about the event. He has complete amnesia to the event itself, cannot remember. So there is two differentiating point between focal aware and focal with impaired awareness. The responsiveness to the environment and remembering the event. Sometimes the focal spread to involve both the cortexes at the same time. We call this focal to bilateral or focal with second generalization. So the focal can be focal motor or focal non-motor. Non-motor can be sensory, can be autonomic, can be psychiatric, whatsoever. Regarding the generalized, in generalized, we have complete loss of consciousness. And complete loss of consciousness occur in all the seizure that lasts for duration more than 4 seconds. So this applies to tonic, clonic, and tonic-clonic seizure regarding the motor type. And even the absence and the atonic usually lasts for more than 4 seconds also. Tonic-clonic I have described in the differentiation between psychogenic pseudoseizure and true seizure. Tonic is a part of the tonic-clonic in which there is sustained contraction of all the muscles of the body with body cyanosis. Clonic with repeated contraction, relaxation, self-wetting, self-soiling, and self-injury. Myoclonic is another story. Myoclonus is sudden shock-like movement like this. We have very momentary. So the consciousness is usually not disturbed in this type of seizure because it's very, very brief. Non-motor is like absence in which there is just lapse of consciousness. Look at me وانا I was describing the absence seizure in which there is lapse of consciousness. I completed what I was talking about because this lapse of consciousness is not felt or experienced by the patient. He looks at the environment. Oh, you are looking at me. Why you are looking, staring like that? Have I experienced a seizure? They say yes, you have. Atonic is like absence, but with loss of postural tone. The loss of postural tone may involve the whole body with falling to the ground, or part of the body like the head or the upper limbs or something like that. And very similar to the absence, but with loss of postural tone. Okay. This patient has absence that started with blinking, and even he has some automatic behavior in the mouse. But look, he is staring, blinking, some automatic behavior in the mouse, which is uncommon. Okay? Can we see other different types of seizures? For generalized tonic-clonic seizures, if you you are nearby to the patient and the patient has generalized tonic-clonic seizure, you have to protect the patient to avoid the injury, the head injury or back injury, something like that. It's very important to put something softly below his head to remove the glasses or necktie to avoid injuries, but don't put anything inside his mouth. Don't uh, limit the movement of the patient at that time. Some people hold the patient. It's wrong. And at the end, let the patient get on his side to get the process out. Look at the patient in the middle. Yes, he has involuntary movement, very short and momentary, but this is usually unilateral, which is not classical. Actually, we watch in most of the patient bilateral symmetrical involuntary movement like that. This is called myoclonic movement. In this patient, it is focal myoclonus. This is very unusual, but actually in our cases, usually this patient has atonic seizure with loss of postural tone only partial, in the head only, not on the all the body. Okay? And this patient has involuntary movement in the left upper limb. While he's fully awake, he's still studying. He doesn't, the involuntary movement even doesn't interrupt the mental work of him. He can remember everything about the event after the end of it. And this patient has, look at this patient, he has staring, looking to the sky, looks as if he's dazed, and then he continues what he was doing. So it's absence epilepsy. Focal with impaired awareness, the patient is not responsive at that time. He is rotating around his axis, not responding at that time, not responding appropriately, repeating the movement purposelessly. And after the end of the seizure, what you have done, I didn't do anything. He cannot remember anything because this is focal with impaired awareness. The motor component is in patient with focal with impaired is more or less automatic and complex. This patient with focal with impaired awareness with psychiatric manifestation, we call this non-motor. Non-motor psychiatric manifestation. This is focal with impaired awareness. He cannot remember anything about it after the end of it. So we described the different types of seizures. What about the cause? Why this patient is having this type of seizure in particular? 50% of the patient, around 50%, for 40 to 50% of the patient will have idiopathic epilepsy. What is idiopathic? Idiopathic means genetically determined disease. If we examine the patient, we shall not find any clinical findings by examination. Cognitive function is okay for this patient. He is fully intellectually. He has no signs on examination, but he carries the gene that makes him more susceptible to have certain types of seizures. The other 50% usually have symptomatic secondary to underlying pathology, like malformation of the brain, trauma, infection, vascular malformation, vascular ischemia, neoplasm, immune-mediated inflammation. So it's very important to differentiate between the idiopathic and symptomatic because symptomatic needs extensive investigations, making the diagnosis of true seizures focal or generalized, classifying it, and finding the etiology, whether idiopathic or symptomatic. You must have your plan. You must be sure of your diagnosis mainly by the clinical history. Clinical history is the key for diagnosis. Please don't miss. And take the history in full details, please. Examination is very important to differentiate between symptomatic and idiopathic because most of the symptomatic has signs. Signs of lateralization, signs of cognitive disability, signs of ataxias whatsoever. But the idiopathic usually has no sign, have no signs, and have very good intellectual functions. EEG is helpful in confirming the diagnosis. It's not diagnostic by itself because some epileptic patient has negative EEG, and on the other hand, some normal healthy persons may have abnormal EEG, although it's rare, but it occurs. So EEG is not sure 100% of the diagnosis, but it's helpful in classifying even the patient. Sometimes we have focal findings that helps to differentiate between focal and generalized. We certain EEG pattern confirm the epileptic diagnosis of epileptic syndrome. It's very important. It helps us in follow-up of the patient when we give him certain anti-epileptic drug in certain epileptic syndromes. But it's very important and helpful in this in the decision of drug discontinuation after a very long period of drug freedom. It's very important. EEG is also very helpful in the making the decision of localization of the focus before epilepsy surgery. So EEG is very helpful, but is not diagnostic. MRI is helpful in establishing a structural lesion that is a cause. So MRI is not diagnostic or even helpful in the diagnosis of type of seizure or whatsoever, but it helps in the etiology when we have a structural lesion in the brain. If you are not sure, please ask another historian or witness to give you full history before making the decision of starting antiepileptic. Sometimes we ask the patient or his family to have home videos using their mobile phones. If it is difficult and the patient has very frequent attacks, we sometimes use video EEG monitoring for confirming the diagnosis and the seizure classification. If it is provoked seizure, don't treat because provoked seizure are not epilepsy. If you have unprovoked seizure, if it is single, we have still have we haven't the diagnosis of epilepsy. But if we have more than one unprovoked seizure, this is epilepsy, and we should start anti-epileptic drug. First line anti-epileptic drug, I discuss in more details with you now. We should try the first line anti-epileptic drug to the maximum dose for up to 2 months. If it fails, we add another one. Push the dose to the maximum for another 2 months. So we have a trial of 4 months. If the second drug fails, usually the third one will fail, and the fourth one will fail, and so on. So we consider this intractable. We think of epilepsy surgery, ketogenic diet, especially for children with symptomatic generalized seizure. Vagal nerve stimulation is helpful in decreasing the frequency of the attacks. Sometimes we put implant devices to inhibit the focus. All of these are used for intractable seizures. This is a very complicated and busy table. I don't recommend you to study, but let us have a good examples for each type of seizure. For example, for focal, I recommend carbamazepine or phenytoin. For generalized, valproate. For absence, valproate or ethosuxamide. For if we don't are not sure of the seizure type, we can use levetiracetam, topiramate, lamotrigine. All of them are nice, but we depend on not only on the seizure type. We consider the comorbidity. For example, if a patient has hepatic disease, hepatitis, something like that, it's not wise to use valproate because it's hepatotoxic. If a patient has renal stone, it's not wise to use topiramate because it increases nephrolithasis. So the comorbidity judges to some extent even the side effect profile. If you have a very intelligent student, it's very unwise to give him topiramate that affects his cognition. If you have a patient old age, it's very unwise to give him carbamazepine that causes sedation and that ataxia. Pharmacokinetics also counts because pharmacokinetics may be important. If you have an old patient who is polymedicated with drug for hypertension, drug for diabetes, and drug for ischemic heart disease, this dyslipidemia, many drugs he's taking. And if you give him carbamazepine is interacting with most of these drugs. So it will disturb the serum level of other drugs. It's not wise to use interacting drugs in this patient. In addition to the cost, which is very important in the financial problem we have in these days. Compliance is another point because some patients cannot comply to a twice daily or three times daily drug. They prefer once daily drug. So it may be of importance because if the half-life of the drug is 12 hours and the patient is taking once daily, it will not act properly. The last part of the presentation is the status epilepticus. Status epilepticus is important because it's a medical emergency leading to mortality and morbidity in many patients. So it's very important to understand these points. It's very critical if you are facing this patient in the ER. Let's start with a basic concept. Most of the seizure end within 2 minutes, 3 minutes, up to maximum 5 minutes. If any single seizure prolonged for more than 5 minutes, usually it will not terminate by itself. So we consider any prolonged seizure lasting for a duration more than 5 minutes as a status epilepticus and start treatment at that time. Sometimes even the seizure extends to 5, 6, 7, 8 minutes. This will consume most of the neurotransmitter at the neuromuscular junction. So the seizure is still acting in the brain but cannot be manifested clinically at convulsions. So at that time, clinically, you will see patient convulsing, then no convulsion, then convulsion regains. This intervening time, the patient will not regain consciousness. So, any patient with repeated convulsions without regaining of consciousness for a total duration of half an hour, consider this status epilepticus. So, we have two definitions of status. If you face any of them, either of them, consider it a status and start treatment at the moment. Single prolonged seizure for a duration more than 5 minutes and multiple seizure without intervening, regaining consciousness for a duration of half an hour. What to do? A, B, C, D, E. A, airway clearance, because many of these patients will have handkerchief or tissues inside this mouth because their relatives would be afraid of tongue biting and they put something inside their mouth. Most of the patients die of these tissues inside their mouth because it blocks the airways. So the first moment, please clear these airways. Pacing is very important because many of the patient are cyanosis on the time of arrival. So please oxygenate this patient as much as you can. Some of them will be shocked, so it's very wise to have two lines and infuse this patient to maintain adequate perfusion, so that the circulation to the brain will react again, and the drugs you are delivering will come to the brain. D-diazepam, which is one of the benzodiazepine, it's very nice drug. We either use diazepam or lorazepam. Lorazepam is not available in Egypt. Diazepam is available. It's very good drug, very cheap drug. It will start action within 15 seconds and its action lasts for half an hour. Lorazepam lasts for more duration but not available in Egypt. Then at the same time we give phenytoin, which is epinotine, epinotine. Phenytoin is now replaced in USA by fosfantine because phenytoin starts action within 20 minutes. It takes 20 minutes to be delivered to the patient. It must be given slowly to the patient, but fosfantine is given within 7 minutes, so it's faster. It's very much expensive. It's not wise to give the fosfantine or to buy fosfantine, which is not available in Egypt. Phenytoin, if it is given, it will start action after 20 minutes And we have diazepam that control the first 30 minutes, so we are covered during these 20 minutes. So the combination of D and E is very suitable for our patient. Phenytoin start action within 20 minutes and give you seizure freedom for 24 hours. So if you start diazepam in one hand and phenytoin in the other hand, phenytoin over 20 minutes and diazepam over 15 seconds, the patient will be seizure free for 24 hours from the time of injection. It's very nice. So let us study the doses. Diazepam is given 10 milligram and phenytoin 1000 milligram. It's 100-fold of the diazepam dose. Diazepam is given for the children zero point 0.2 milligram per kg and phenytoin 20 milligram per kg. It's also 100-fold the dose of diazepam. So it's very important to study the doses. Phenytoin can be replaced by valproate intravenous infusion. It's not available in Egypt. It's not available. Levetiracetam can be given slowly, but you must be sure that the patient renal function is okay because levetiracetam is only excreted by kidney as and contraindicated in patient with renal impairment. So phenytoin is the cheapest and safest at the same time, but must be given very slowly. If you give diazepam and phenytoin, the patient is still seizing for 1 hour after the start of this infusion, you have to intubate the patient and give intravenous anesthesia. Intravenous the thiabental sodium, pentobarbital, propofol, or continuous midazolam infusion. Either of them will be helpful according to the availability and the blood pressure of the patient because propofol causes hypotension and midazolam is not available in these large doses in most of the hospital. So a specialist will help you in that at that time, but you will save most of the patient if you follow the ABCDE rule I have described. Thank you very much for your attention. Wishing you a good luck and nice stay in our department. Thank you.